Hospital, and then the facilitator of our research day here today. This is an event that's a collaboration between the Royal Ontario Medical Program, the town of Collingwood, Georgian College, and the Collingwood Hospital here. It's quite fitting that the event is a production of collaboration, since one of our main goals is to really enhance collaboration between and amongst health and wellness professionals in the community. So this is a great example of bringing us all together here today. Some of our other goals here today are to give you an opportunity to network, learn and explore some of the great research and initiatives taking place in Collingwood and the surrounding area. As you see walking in the hall, you see there's a great number of posters lining the halls. We're going to have some great speakers today. And you'll see your fellow attendees, representatives not just from CGMH, but from a wide variety of organizations and community practices. And in our crowd, we have midwives, our family health team, residents, our OTN team members, physiotherapists, wellness professionals, chiropractors, dentists, counselors, teachers, and much more. And really thrilled that you're all here and quite excited. We decided to have a few streams this year, and so after the break, we're going to have our theme on youth mental health. According to our Mental Health Commission of Canada, this Canadian Mental Health Association, Children's Mental Health in Ontario and the Canadian Institute of Health Information, about 1.2 million children and youth in Canada are affected by mental illness, and 1 in 5 will go on to have significant morbidity from this. Now that I've just given you a taste of what's to come, we're going to have some great speakers on that. I want to take the opportunity just to thank individuals that have made this happen. I just want to thank our Royal Ontario Medical Program, Dr. Peter Wells, Michelle Hunter, our students, Jody, Becca, that have made this happen, our town of Collingwood, Martin Ridlow, Georgian College with Phelan Lambie, Sarah Lancashire, Jacqueline Limoges, and Lynn Hine, and our team members here at the CGMH, as well as all of you in the community. And we really do appreciate and really do acknowledge all of the efforts that you all are putting into today's work. A bit of housekeeping. We have some evaluations that are included in your package. There is a mental health survey that we'll ask that you to complete prior to the mental health stream. In addition, there's an end-of-day evaluation that you'll get later on as the day progresses. So at this point, I'd like to introduce Dr. Peter Wells, the Executive Director of the Royal Ontario Medical Program. And he's going to come up to say some words and to give some introductions as well. So thank you very much, Peter.
Good morning. Welcome to all of you. It's wonderful to see all of you here. The room's almost packed full. It's wonderful. It's so great to see such a diverse crowd. Michael has mentioned the diverse professionals and community members we have joining together for our research day. I want to take a moment to recognize the bright idea and leader behind this day, Dr. Michael Lisi. Dr. Lisi was awarded the honor roll status in the 2016 Minister Medal honoring excellence in health quality and safety. So that's quite an accomplishment when you think that that's a provincial award. The provincial award recognizes Dr. Lisi's leadership for the inaugural Georgian Bay Interprofessional Education and Research Day, and yes, I said it all correctly, I think, held at this time last year, and so we were all gathered together last year for the same sort of activity. As stated by Dr. Lisi, the Research Day is about community partners coming together to share and promote healthcare in our community. It's not just everyday healthcare experience, it's about innovation, willingness to strive for continuous improvement and patient-centered care. This concept of Research Day and the values that we've embedded in it are values that we aim to incorporate in all aspects of our healthcare practice for our community. I just wanted to say that this time last year, I think it was exactly the same weather, and we had a good crowd last year, and so we've got a great weather this year. And so, Dr. Lisi, I want to always be part of your team because you obviously bring great weather. I want to take this opportunity to thank Dr. Lisi for his commitment to education, enabling the group of students who have worked as a team on this event. I would like to read out their names. I'd like them to stand and stay standing. Jody Hooker, a McMaster medical student. Rebecca Keenan, Georgian nursing student. Claire Linton, UWO pre-med student. And Kylie Forster, Fanshawe graphics student. These are the folks who have really put this all together, so I'd like to give them a round of applause, please. When we integrate learners and students into our organization's community, we are demonstrating our commitment to continuous education and collaboration. The Royal Ontario Medical Program works with communities and students together, as this is the foundation of our future healthcare system. And I certainly believe that, and some of our speakers were innovators and leaders several years ago. Dr. Tepper is going to be saying a few words later. Collingwood is a leader in the community-based education and innovation. There are a number of posters in the hallways that have been referenced. I would like you to, during break and even after the conference, take time to go look at them. They're very thoughtful. They contain a lot of material. They're very interesting. I hope everyone enjoys today's event. Please take advantage of the opportunity to network, to gain an understanding of the types of innovation and change taking place uniquely in this, our community. As a final thought, a quote from Margaret Mead, "Never doubt that a small group of thoughtful, committed citizens can change the world, and indeed, it's the only thing that ever has." Thank you.
So now I'd like to introduce Phelim Lambie as the Dean of Health, Wellness and Sciences at Georgian College to bring some opening remarks as well.
Good morning, everyone. Thank you so much for the opportunity being here today. I must say, Dr. Lisi, it's remarkable to see another successful event after a year ago of planning and launching this inaugural day. So it's wonderful to see you all here today. I just wanted to extend, on behalf of Georgian College and the School of Health, Wellness and Sciences, a warm welcome and thank you for allowing us to participate in this day. I think our community is absolutely fortunate to have such commitment and partnerships, truly passionate about health and wellness. When you leave today, I am quite convinced that you will leave here feeling more inspired, more energized, more informed, and absolutely more delighted in the company and the knowledge that will be imparted on you today. I think all of us in this room, whether we're educators or healthcare professionals, have had the great privilege of working with clients from diverse backgrounds and with diverse comorbidities and illnesses. Today you will see a number of posters and information and research presentation that really focus on mental health. And as we are talking about health and wellness, I think it's imperative that we take the knowledge that we gain from today and figure out how we can join together more collaboratively to bring support and great advocacy to this agenda. As a community of healthcare providers, clinicians, committed totally to building capacity and creating awareness, this is a prime opportunity for all of us. I thank you so much for this opportunity. Enjoy the networking and the collaboration, and look forward to a great event. Thank you. Oops. I was taking you with me.
Okay, great. Our first speaker for the day is Dr. Joshua Tepper. And Dr. Tepper is a family physician and the President and Chief Executive Officer of Health Quality Ontario. Previously, Dr. Tepper served as the first Assistant Deputy Minister at the Ministry of Health and Long-Term Care, Health Human Resources Strategy Division. He was also the inaugural Vice President of Education at Sunnybrook Health Sciences Centre, a Senior Medical Officer for Health Canada, and an Adjunct Scientist at the Institute of Clinical Evaluative Sciences, and a Research Consultant for the Canadian Institute of Health Information. Dr. Tepper has a degree in public policy from Duke University, a master's of public health from Harvard, and an MBA from the Richard Ivey School of Business. We're very thrilled that he's able to take time on this day to come and speak to us today. So thank you so much, Josh, for in.
So good morning, and thanks so much for having me. First of all, it's just a fantastic day. I looked at a bunch of the posters, not all, to be clear, but many of the posters, and read about the sort of event and learned about all the people online. And I have to say, if you could imagine that every community in Ontario got together in this interprofessional way, combining the different parts of the healthcare system to focus in this way, what a tremendous difference it would make. And the research, the quality improvement, the focus on wellness, the acute care, the community, just really all focused, the educational system coming together. I don't know if it's completely unprecedented, but it doesn't happen often enough. And huge credit to everybody who pulls this day together, and particularly to you, Michael. What Michael doesn't know, actually, is that I chair the panel that gave him the honor roll position last year for the Minister's Medal. It's one of the great parts of my job is every year to go through the applications. And there are a lot of applications every year, and there's some pretty phenomenal nominations from across the entire province. So that is an award well earned. And a recognition well deserved. So Michael, congratulations. I do remember reading the application last year with the committee, and again, you stood out from a very large application pool, so congrats on that. And we'll be taking nominations again this year, so we'll more back again. And also I have to just sort of acknowledge Michelle and Peter. I've known them both since medical school, which was not that long ago, but a while ago, and quite a while ago. And it's just amazing to see both of you again. Thank you for having me back, and just your leadership in this community has been fantastic over so many years. So just thanks for having me. So actually, when I talk about quality, I like to talk and start actually with patients. And so the first two patients are patients that were just on my list from a couple Mondays ago. And the third one was somebody I saw on Emerge later that week. And so the first patient I saw was a gentleman, 71-year-old, and he came in for a pre-op for a hernia repair. And he's a pretty, what I would call straightforward patient, and a little bit older, but generally in good health, minimal medications, some high blood pressure. And I actually feel pretty good about the quality of care that I feel I could give and that he is likely to get. Even the process of filling out the forms, I always wish hospitals could find one pre-op form for family doctors. But, I'm happy to use whatever form they like, and I felt confident that it would get there. And I also felt confident that actually should something unfortunate happen through the course of his operation or post-op care, that it would float up to the senior levels and it would be identified, and, chiefs of staff would sort of pay attention, and there's a regulatory and a framework and a critical incident process that, heaven forbid, something didn't go well. They would sort of study and learn from this process. And so I feel pretty good about the quality of care that this individual was getting and would get. But this is the next patient who is on my list. So she's 56 years old. When she came to see me for the first time about 3.5 years ago, she had not left her house for 5 years. Outside of about 150-foot walk in front of her house where she walked her dogs every day. Her level of anxiety was so high, and her agoraphobia and her anxiety and her depression and her deep, deep trauma history was so high, she could not leave her house. And the only way she came in, and the reason she came in to see me that day was because she had used all of her resources and within days of being evicted. She had run through all of her savings. She ran through all of her credit cards, all of her family's savings, everything she had, every penny, and she was within days of being evicted from her housing and was to end up on the street, and in fact did. was within 3 or 4 days of my seeing her evicted. It was so hard for her to get out of the house. She came in under the influence of several substances just to be able to cope with the anxiety of being outside of the house. We started to work together. I discovered she had HIV. She didn't know she was had positive. I then discovered a tumor. And we just started to deal with her trauma history. And she's an incredibly complicated patient. And what I don't feel confident about is, what does quality look like for her? How do I measure quality for her? How do I assess quality for her? How do we work as a system where, in fact, the most important person on our healthcare team is not me as her family doctor. It's actually, initially, it was the housing team, which I know very little about, that had to get her housed in a very short order of time so she did not end up homeless. It's actually now about the mental health team, who's dealing with this and one of the hardest cases of trauma and physical and sexual abuse that I've heard. And I do a lot of trauma work and torture work in my practice. And you know, that is the most important part of her team. And now when I talked about her, what is her biggest care goal that she would like? What is the one thing she would really like? She said, I would like to continue my gender-conforming surgery. That is my primary goal. That is the thing I would like most of all to achieve in my life. And now I'm working very closely with Montreal across the whole border to think about how do we manage this care. And I can tell you, I don't have the same confidence in managing her care and the quality of care and the measuring of her care and understanding what it looks like that I do on the first patient. So what does quality of care look like for somebody like this? And if you think this is only a patient you see in downtown Toronto, you're not looking hard enough in your own patients. And then I was working in Emerge, and this was sort of towards the end of my night. We'd shifted from the sort of core, the high acuity complex part of the patient. Sorry, I'm going to get my 10,000 steps in the next 40 minutes, so you just keep up. You know, I moved into the ambulatory zone, which is a bit more of our fast track, and sort of move things a little bit quicker, and sort of towards the end of the shift. And this woman came in, and she was 49 years old, and the chart said she'd fell 3 weeks ago, and since then she'd sort of had this headache. And I sort of saw her and said, you worry about a subdural and stuff. And I just knew as soon as I saw her that she looked pretty sick. And she was a young woman. I chatted with her. She was there with one of her 2 young children at sort of 2 in the morning in the Emerge, because her partner, her husband, is in a shift job with a lot of, works out of town, very difficult as they work to make ends meet. In fact, she told me, in fact, they couldn't afford to live in Toronto and were actually moving far outside of the GTA to find affordable housing. And so she was here with her kids. She was so apologetic for having her child up in the middle of the night, but this headache was so bad. And I looked at her, I said, I don't know, we're getting a CAT scan here, worried about a subdural, 49 years old with a fall. She was in a lot of pain. And the CAT scan I got actually paged over her head by radiology. It's pretty unusual for me to get paged by radiology in the middle of the night. Nothing to that, they're saying. And she called and said there's 15 or more lesions in her head. She had metastatic cancer. So that was the rest of my night, was with her, sitting there in a crowded Emerge. She was now in the hallway, talking about this with her. And, you know, this is the patient that has now been 2 weeks later that I still think about every day. I texted her yesterday, because I text her every few days to see what's happening and how she's doing. Because part of the quality of care that we need to think about is the quality of care for patients. But the other part of the quality of care agenda that we need to think about is the quality of care for the healthcare providers. And what I really love about your day is, yeah, it's interprofessional. I love that. It's community and it's acute care. It's fantastic. It's multi-community. But the other thing that you're talking about today is wellness. And a lot of the success of our healthcare system relies on the resiliency and the health and wellness of the hundreds of thousands of people who deliver care every day. And how do we help the people who provide incredibly important, good, high-quality care to people like this, but then go home and hug their kids a little tighter, who wake up every day and say, I'm just going to send a text, who worry about how many times they didn't order the CT and maybe should have, who wonder, what else could we have done? Is there a way that there's some way that our system or individually we could have done better, that a 49-year-old doesn't end up with metastatic disease and emerge? These are the things we all live with every day, and part of a high-performing quality system is focusing on wellness, resiliency, and support for everybody at the front line. And so actually, I'm going to tell you one more story, and then I'm going to maybe just open it for questions, if that's okay, because I think, Michael, you'd like to stop around 9:10. Is that fair? Have I understood your agenda? Yep. I'll tell you one more story where quality is really hard, and this actually came in just the other day. And again, it speaks to the challenge of delivering quality care. He's a 51-year-old homeless gentleman with end-stage liver disease. And he is in and out of the hospital, was in and out of the hospital every, I would say, 7 to 10 days, either to have his paracentesis, his bloating, his ascites drained, or because he was bleeding, again, from the complications of his end-stage liver disease. And so he was on the transplant list, and the transplant team was very reluctant to take him because he's transiently sheltered. He has no social supports. And so we promised to try to create a team around him that would allow him to have both the pre-op, but more importantly, the post-operative transplant care he needed. And so we worked back and forth with the transplant team. And then I got a message from our social worker one Monday morning that said, we have a problem. On Saturday night, a liver was available, which was a miracle, frankly. Like, it does feel sometimes nothing short of that. Of course, it's a complex system working hard to put patients first. But my patient, who lives well below the poverty line, his cell phone had run out of minutes. They have no other way in his shelter system of reaching him. He was moved off the list. And when the social worker went, and then they sort of actually, to their credit, sent some people, tried to find him, et cetera, couldn't find him. And then when they did find him, and the social work team and the paramedic team sort of brought him in, it was too late, he missed it. They noted that there was alcohol, beer in his room, beer cans in his room. So here's the letter I got 3 days later. It said, we are discharging him from the transplant team. He no longer qualifies. Although there was no alcohol in his urine, or in his bloodstream, not his urine, in his blood, and although he denies taking alcohol, we're concerned he's not compliant. He couldn't make the appointment. He didn't answer his phone call. He's off the list. 5 days later, he died. He bled out in his apartment. That was 6 days ago. The challenge we have of quality care is the easiest on patient one. It is hardest on these other patients. But our quality of care that we commit to as a healthcare system has to be for everyone. And so what I would ask you to do as you think about your QI projects, as you think about interprofessionalism, as you think about wellness, as you think about the patients that you're focused on for better care, is think about them all. And as you think about them all, the people you need to have in the room need to be very, very different. Because the type of people I need for patient one is largely, I think, Michael, you're a surgeon if I'm not mistaken, sort of the two of us, and then your surgical team, right? Like, I'm a family doctor and stuff. The type of people we need involved for the rest of these patients are very different. It's the police, it's the judicial system, it's the housing system, it's the education system, It's interprofessional in a way that we've only begun to think about interprofessional. But if we want a high-quality system, that's the team we need. That's the type of focus on wellness we need for people who deal with the complexity and the hardships of the patients we're here for every day. Thank you very much for having me. Thank you for a day that we need more often in Ontario. I'm happy to take a few questions with Michael's permission. I'd love to take a few questions. Or comments or whatever. Peter?
Josh, how do you, in trying to provide quality to patients, the emphasis right now is on the providers, all of us. How do you engage patients and try and tell them they have a role to play here as well?
Yeah, you know, I find this, if I can be blunt, one of the most challenging conversations right now. I have to remember I'm being videotaped, so let me be super careful. Because there is this very interesting balance. And I think physicians in particular, but healthcare providers in general, feel this increasing push towards towards provider accountability, oversight, government role, and accountability. And yet at the same time, I think very reasonably ask, what is the patient's role in this? And what is the patient accountability? And how do we engage them in their care? And I think we absolutely need to have patients involved in the quality agenda. I actually think the patient engagement, patient centeredness of our care is actually one of the most powerful tools we have for quality improvement, and one of the most transformative things that have really advanced the quality agenda. And so when you see, you know, these unbelievable YouTube videos, these unbelievable stories of patient family advisory councils, when you see patients engaging in their care, it is truly transformative. What I think we need to be cognizant of, though, is what is the type of expectations and responsibility that we can expect from patient A versus patient D that I don't have listed, right? Here's a gentleman who's never finished high school. I'm pretty sure he'd never finished high school. I say that with an 85 degree of confidence. He had a baseline high degree of cognitive sort of limitations. His hepatic disease gave him a hepatic encephalopathy, which further blunted his cognitive state every day. He was deeply impoverished, as I've talked about. And so his capacity and resources to be responsible in his care are different. So does he have a role in patient-centered and patient engagement? Absolutely. Did he literally come in every day advocating for his own care, advocating to be on the list, doing everything he could? Absolutely. But is he more limited in being able to participate and take accountability than patient A? Absolutely. And so we do need to have accountability, but it needs to be contextualized into the capacity and the ability of the patient. And we need to be really careful as well to think about the cultural competency of our system, the racialization of our system, the language barriers of our system that we need to address when we say, and now you need to be accountable for your care. Because it's very hard to be accountable for care when there are structural barriers to that engagement that speak often very much to structural issues of education, structural issues of language, structural issues of income, structural issues of racialization, and other barriers. So absolutely it needs to be there, but we need to be able to be so thoughtful about how we do that. And the first step is to engage and relentlessly engage and relentlessly reach out to have patients and their voices and their caregivers participate. And even at HQO, where we're very dedicated to this, we don't have enough people who have the greatest barriers to care involved. And so when we want patient engagement, how do we make sure it doesn't look too much like the average distribution in this room solely, and also have the voices of people who do not look as much and represent the education level and the income level of this room? Because those voices are important, and that's how we can get towards accountability, is by bringing their voices in and say, what is a reasonable responsibility and accountability for you to have? I'll make the next answer shorter.
Compared to 15 years
But try to not ask anything I care that deeply about.
compared to 15 or 20 years ago, are you seeing more anxiety and depression in youth?
Yes.
And
I told you I'd be shorter.
why do you think that is? Or do you think it's related to diet?
That's a good question. I think there's a wide variety of things at play, and I wouldn't hold myself up as an expert. I do feel, and I do think the studies support a much greater degree. To some degree, I think there's also an issue that there was historically underreporting and underdiagnosis, and there's and stigmatization. And I think a lot more now people are looking for it, screening for it, asking about it. I've got an 11-year-old, and there's much more open discussion about it. What's that Netflix series? That one. Where there's a Netflix series about a teenager who commits suicide. That wasn't 20 years ago, right? And there's all sorts of controversy around is this sort of, I appreciate the controversy, but it's still a discourse in common society that isn't there. The issue around diet, I'm going to take a pass on because I don't feel I know the evidence base solidly enough to give an answer. There's a question over here, sir.
Can you give us any examples of communities that are doing it right, doing it well in terms of achieving the quality through integration and collaboration, whether it's in Ontario, elsewhere in Canada, or abroad?
I think a lot of places do it well. Like, I would argue you guys do it well. Like, this type of day is something that I opened with by saying, like, why can't every community have a day like today with this type of collection of intellect, passion, interprofessionalism, education, etc. So everybody is doing some things well. Not everybody is doing all of the things well or sharing it well, right? And so, like, I'll hold my own clinic up as an example that does do a good job. We have a very active participation in the diversion program from the judicial system. The local police have a high level of training on how to deal with the mentally ill in a way that helps violent altercations. We see a judicial system. One of the biggest things my clinic does is we run tax clinics because one of the most important determinants of health, in fact, I would say the number one determinant of health is income. Followed closely by education and housing, and arguably income is a driver of housing. So one of the best things we can do is actually get people to file their taxes and get some money. And so we actually run tax clinics. So we have on our interprofessional team, we basically have access to police, accountants, social work, housing experts. We have a wide range of things. And our clinic has a small medication cabinet, like most of your clinics, but we also have a whole closet full of shampoo and soap and shoes and clothing and clean socks and donated clothing and books, children's books for literacy and education. And so, that is a broader definition of a primary care clinic than I think many people do. I'm not saying we have it all right, and better has no limit, as we say at HQO, but I think it starts to push the thinking of what do our patients need and what should we be offering as a primary care team for our local community.
I just have a comment. I would be working with the patient B, C, and D.
Yeah.
I actually know a D, exactly. And I think what my comment is when you said that we have to think about professionals' care of their mental health as well. And I go to patients' appointments with them so that I can help interpret what the doctor's saying. And a lot of times they don't feel listened to when they are, but they need me to say that. So I think that our side of in the community,
Right.
we're trying to teach people that the doctor does care about them. They're just so complex that it's hard to focus on one issue.
Mm-hmm.
And oftentimes the issue isn't their health, like you say, it's their
Right.
where they're going to live,
Right.
where they're going to sleep tonight, and how are they going to pay for bills. So I just wanted to say thank you because when you said that, I thought that's exactly what we're trying to promote with our people.
And let me be clear, I am incredibly lucky. I work in an incredibly well-resourced primary care team. I work in a family health team. I also work in the smallest family health team with the homeless shelter I work in. But my other site is one of the largest academic family health team in the province, and I have an abundance of resources. And when I see patients like B and D in my primary care practice, I cannot imagine how I could begin to cope if I was a solo-based or 2-doc-based fee-for-service family physician or some other model with 3 or 4 docs. I could not provide the type of care, when I say because I have a team there. And so I want to be super clear that I believe every provider goes to work every day trying to provide excellent care. I do believe we need to create the systems in place around the provider and to support them in their patient-centeredness. Because again, I don't know how I would begin to have provided the care I've been able to for patient B or D, despite the what I feel was almost inappropriate ending. Without the type of resource, and I can't imagine what it would be like for a two-doc, like the thing, you know, I trained in Grimsby for a little bit, and I trained in a bunch of small towns, and Collingwood, didn't train here, sorry, what am I thinking of, Godridge. You know, and I can't imagine having cared for these types of patients in that type of infrastructure, so we need to really be so cognizant of that. All right. Roughly on time, Michael. All right, thank you. Thank you very, very much.
Thanks, Doctor. On behalf of our
Thank you.
group here, thank you so much, Dr. Little token of something for making the trip. Thank you
No,
so much.
thanks for having me, Michael.
just,
Oh, you want this back? I thought it was a souvenir.
Thank you so much. Okay, so first of all, thank you, Dr. Tepper. That was fantastic. We greatly appreciate it, and thanks for making the trip up. And I'll do the intros for our next speakers, who are Dr. Jacqueline Limoges and Dr. Sarah Lancashire. Dr. Jacqueline Limoges is a PhD RN, as a faculty member in the BSN program and researcher at Georgian College. She's also the chair of the Georgian Research Ethics Board and member of the Ontario Cancer Research Ethics Board. Her teaching and research focus on collaborative practice, health systems, and ethics. Dr. Sarah Lancashire is a professor of nursing with Georgian College in Barrie, Ontario. Her areas of research include professional practice structures and roles, scope of practice, role clarity, and application of nursing knowledge. She has extensive experience partnering with a wide variety of healthcare organizations who seek out her expertise and passion for creating systems, processes, practices that enable optimal professional practice and quality patient outcomes. Thank you for coming today to speak to us here.
How does this go? You just might have to hold. Might have to hold it. Is it? We were having a hard time hearing Michael. Is it a little better now? No, still. We need it maybe a bit louder.
I'm just gonna do this to you. Try that.
Is that better? Is this one? Oh, so.
I think that one's for the online.
Oh, so we have to stand behind this? This is how you avoid talking. You spend the whole session thinking about the microphone and the flicker. Thank you. So thank you. I think it was a really good segue for us to have the opportunity to speak after Dr. Tepper. Sarah and I were thinking about what we would speak about today and thinking about the incredible opportunity that we have, given who's in the room, to think about what's happening around the healthcare context. What kinds of supports do we have to help us do the types of things that Dr. Tepper was talking about? You know, patient B and patient C and patient D, the really challenging patients. And so we thought we would begin and end with the same question. How can we use our networks of collaboration? How can we use the fact that today we have cross-sectoral people and representation in the room to think about what we're doing and what can we do? So when Sarah and I got started, we were at her home and we started thinking, what's changed? You know, we're kind of old gals. We've been in the field for a long time. And we started thinking about, you know, what's really been shifting in the last while and what opportunities present to us given this shift. So we came up with all of these little Post-its, our really big pieces of legislation, big initiatives. And we started recognizing that there were sort of three streams of things happening. And so we thought we would try to present a snapshot of some of the shifts, and we do want to save some time for some discussions as well. And so what we noticed from the time that we started nursing is a real, at that time there was a real focus on the expert ideology. So the healthcare practitioners were considered to be the experts. And we're recovering from that in terms of what's been happening in healthcare. And so there are three focuses or foci that we're going to have and speak about. So I'm going to start off, and then Sarah will carry on. So as I mentioned, or was mentioned in my introduction, I'm quite involved in research ethics, and I have a little bit of a research program. And when I think of what's happening in terms of discourses, in terms of policies, in terms of guiding documents, that can be useful for us to think about how do we put the patient first. So there's been a shift even in terms of language. We used to call people who participated in research subjects. And now they're actually research participants. And so there's been quite a shift in the way that we obtain consent from people participating in research. And the shift moves along all the way to this strategy right now that is quite useful to us in looking at how do we produce knowledge that helps us to do the important work that we're trying to do as healthcare professionals. So there's a movement right now called the Strategy for Patient-Oriented Research. And if any of you in the room have tried to obtain research funding recently, you will notice that unless you have patient involvement, the participant involvement, unless you have cross-sectoral involvement, it's really unlikely that you're going to get research funding. There's a real movement that the patients need to be part of generating research questions. So no longer is it, academics in an ivory tower thinking about what would we like to know. It's really about what do we need to know to provide the important work that we've been asked to do in terms of healthcare. So it starts to really shift the kinds of questions and the kinds of research agenda that we're seeing in healthcare. So there's opportunities for us when we're in a room like this to think about what do we need as a community in the North Simcoe Muskoka LHIN? What types of knowledge do we need, and how might we go about talking to each other to find out the kinds of research projects that we should be supporting and advancing? There's also quite a movement in recognizing that there are differences in the people that we work with, the patients, the participants. There's quite a strong focus now around recognition of gender and diversity. And so just as Dr. Tepper talked about, there are patients that are more challenging to serve. If we think of patient B in terms of the transgendered patient, there's a real focus now in terms of projects that are being funded that recognize diversity, that recognize gender difference. And so again, when we start meeting in these types of collaborative networks, we can start thinking about how are we asking research questions and how are we thinking about the projects that we're engaged in that address those really difficult to serve people. The system was originally designed by experts, people like us who came from certain walks of life. What's being asked of us now is to produce knowledge that helps us to develop systems for the people who need it most, those difficult to serve patients. So the challenge for us is to think about those questions and to think about the research questions that give us knowledge to serve the most challenging people to serve. And so what we're moving to is individualized and personalized healthcare, but with a focus on community and groups of people. So it's quite a shift from the ivory tower and researchers coming up with questions and having research subjects to really having the people that we're producing the knowledge for actively involved in the generation of that knowledge. So I'll switch now to the second process in terms of our line of those crazy Post-its that we had. And it's really this notion of patient as the passive recipient of care. And there was a time when, we just kind of did things to patients. And there's a real shift now that we're doing things with people, that every structure is being organized. And Sarah's going to speak in greater detail about some of this. But when we think about the policies, the initiatives that are happening that can support us to do this work, it's pretty exciting. So we're really looking at issues of autonomy and self-determination. And culturally, within Ontario and within Canada, Canada, there is a growing understanding of how we direct our own lives, how we have choice and freedom, and how diversity is recognized and celebrated. And so I'm going to turn the microphone over to Sarah so that she can talk about some of the initiatives that bring us to this notion that we're really organizing our care so that the patient truly can be first.
Thank you. Let's see how this goes. There you go. Here we go. Alrighty. Thanks, Jacqueline. I'll take that too. So some of these areas that Jacqueline mentioned in terms of really now recognizing, as opposed to that patient being that passive recipient, is the recognition of the autonomy and self-determination of the patient, that they are actually the experts of their own care. Whether we agree with what their choices are or not, they do actually get to determine their care. The whole notion, if you think about the choices, again, with Dr. Tepper's patient population, in terms of his comment that patients decide what quality outcomes are for them based on their experience, and how do we really embrace that? That's a huge shift. I think we're seeing that from a cultural shift in healthcare right now. There is the recognition that the patient is that autonomous individual, and they should be deciding what is quality to them, versus being that passive recipient where, as care providers, we would decide what the plan of care is, we'll decide what your outcomes are, and thank you very much. So really looking at that notion of the patient being very well educated in terms of what their various degrees of education perhaps, but again, they are the most educated about their experience and what makes sense to them. And now also looking at the shift of not only patients, but also family members and the extended caregivers that are involved within the patient as well. And for us also looking at populations as our patients. For those of you that are in public health and primary care, it is a population that you're actually providing care for. So how do we extend our knowledge about an individual patient, but how are they a reflection of the individuals within our community? And how do we bring that notion forward? And again, the whole notion about patient safety and cultural safety that Dr. Tepper also mentioned. So when we talk about patient safety, not only just the notion about their physical safety in terms of preventing any harm, but expanding that to the notion of psychosocial emotional safety, recognizing the spiritual components and the cultural components that are very much involved in individuals' definitions of health, and how do we bring that forward? And how do we bring that into the plan of care, and making sure that we're having the patients describe to us what is important to them in terms of their overall health, looking at them as a whole patient, not just as that disease entity or episode of perhaps illness that's in front of us now. And now the whole focus really on looking at patient outcomes. Excuse me. So not only looking at from evidence-based practices and what looks good in terms of patient care outcomes, but again, making sure that the outcomes we decide, if you will, to use that language, again, resonate with the patients. So again, you're seeing a much, much greater involvement in terms of patients and family and caregivers, and I'll extend this even into long-term care where you have resident councils as well, deciding what is the experience for you. What makes a good healthcare experience? What is important to you in terms of with regards to health? And how do we make sure we bring that notion in terms of our care? So the shift is recognizing the patient is the expert. They know themselves, they know their context of health, and we really have to embrace and recognize that the patient is indeed the expert, that they are educated and informed partners. So we can talk about different areas in terms of, again, those social determinants of health, but again, they are educated in terms of their own life experience and what works well for them and what they bring in terms of that experience as they go forward. And also recognizing that shift really, as Jacqueline mentioned, instead of we as the experts of everything in terms of healthcare providers, we are there as a support and resource to our patients, families, and communities in terms of their overall health and wellness, and what are the resources that we can actually help to perhaps navigate through the system to actually continue that going forward. The last area is looking at the whole notion of what used to be care provided in various silos of care, and now really looking at a much more, we hope, integrated approach to care. For those of you who have been around a long time, like some of us, the care used to be provided around departments. There used to be a department of nursing, a department of medicine, a department of physiotherapy, and we would engulf and show up on the units. Now care is actually what was called a program management model of care, where care is centered around patient populations. And based on that patient population, that determines then What are the care providers and the resources required to care for the needs of that very, very distinct population? So placing the patient at the center and moving the care from there. The notion of, again, another additional structure is the notion of the patient family advisory councils that are now well ingrained, really in place. And now with the additional, with the Patients First legislation, we're actually now seeing patient family advisory councils at the LHIN level. So again, really incorporating the voices of patients, families, and caregivers in terms of what is that healthcare experience? What does quality look like to you? What is important to you? And how can we make sure that we are actually supporting care from that very, very specific perspective? The interdisciplinary collaborative models of care, again, recognizing, as again Dr. Tepper talked about, what are the various different team members, and even that is continuing to morph as we go on. So the inclusion of considering the things such as the social determinants of health. Is the real issue here that of housing? Is the issue about food insecurity? So who are the other members of the team that we really need to have around the table to meet the very complex needs of the very patients or the patient populations that we have? So continually being able to tap into the wealth of expertise of many types of regulated and other types of professionals to really support the needs of complex families and the care that they actually need. And within that, we're looking at cross-sector transitions of care. So recognizing, as opposed to silos of care, acute care, rehab, long-term care, really looking at how do we try to make those transitions much more seamless. So again, with the focus on the Patients First legislation is really looking at how do we make those transitions much more seamless so that the patients get the best possible care from a wide variety of healthcare professionals. When you talk about, you hear individuals from the ministry and they talk about this transition, they talk about very clearly that primary care they see as the home health for patients. It's not about acute care and episodes of illness, but it's about how do we have care close to home and how do we look at really what are the care needs for all those individuals. So again, the shift here is really looking at now the whole notion of about really health promotion and wellness, which is the focus of our day here today. So looking at some of those upstream strategies. How do we prevent illness? How do we promote health? How do we look at those things in terms of the antecedents, if you will, to really good health care? Looking at care close to home. How do we keep people in their communities well, and how do we look at providing care that's meaningful to them? And really looking at having healthcare providers working across those intersectors and really functioning in a very, very collaborative way. So how do we bring all these very different pieces? I think the shift is really quite significant. I've been a nurse for 35 years, God bless me. And the shift is significant. It's a cultural shift now. It is totally different. There's some people that still kind of struggle with it a little bit, but we really look at the whole notion about the patient is there. We are there to serve the patient. So we really have to look at how do we expand that from a much broader perspective. So as Jacqueline mentioned, as opposed to having some, that expert ideology, you're here to listen to me, I'll tell you what's wrong with you, I'll tell you what's best for you, and that's it. To really looking at the notion, it really is about patients first and having that full shift, that the patient is a full partner within this experience. Without that partnership, we really won't have those great positive outcomes that we really want to achieve. It is all about those transitions of care. Whether it's from public health to primary care, episodes of illness, it may look at rehab, acute care, but looking at care back close to home, and making sure that we are outcome focused. But the outcomes, again, are driven by what's important to the patients. What do they determine to be a good quality outcome and a good quality experience, and how do we build from that? So those are some of the shifts, we've seen. There we go. So we'd like to almost bring it back and think about, look at from what your experiences are. So really, how can we, as the various players, all of us here together, individuals in the room, patients that have formal roles within healthcare or other individuals, how can we start to make this shift and actually continue to make this shift forward? And perhaps you can share some of your experiences of what you've seen in terms of really changing that focus to having the patients first. We're just curious to what some of your experiences are. Or for individuals in the rooms that perhaps have been patients, what has been your experience? And are you starting to see a bit of that shift? Yes?
I think it's very noble talking about the patient as being the experts, especially when you take the demographics of this area, and we have the highest demographics of over 55 in Canada, I believe. So again, I don't see, I think it's great to see you moving in that direction. But in our area, actually educating people because of their age to think that they can actually really interface with their healthcare giver that is going to make them feel a lot better because there's a collaboration is a challenge. And I think that I don't know what you got to start somewhere.
Yep.
And this is a great collaboration here, but it's a real challenge. People in this demographic, in this area, don't want to question doctors as healthcare givers. So we got a huge job to do.
That is a really key point, and that's part of that old artifact piece, right? So we put ourselves up at the experts, so now everybody expects us to be the experts, and you're right, that's part of it as well, is even making that cultural shift within the patient population to say, no, you are a full partner. I need to know from you what's important to you. So how do we recognize that yes, whether it's an old ideology in terms of don't question healthcare professionals. There's also some very cultural aspects, literally, in terms of you don't question anybody's authority. So you're right. So how do we start to signal those messages that this is almost an expectation that we need you as that full partner if we're really going to provide excellent care? I don't know, Jacqueline, if you want to add any.
Well, and I think some of it from our angle, we look at how are we educating nurses. That's the primary job that we do. And we think that some of how we can support this is the way that we're teaching health practitioners to engage people. It doesn't mean that the healthcare providers don't have expertise, but we use that in support of the patients. And so it's looking at how can we create health systems that put the patient at the center and make them equal participants of care. And I think that's our challenge, and that's part of how we can collaborate and network, so that we've created systems that support that if that's what the patient wants. So again, it's back to these central notions of autonomy and self-determination. So it's part of, it's an evolution, but when we come together as we are today and we start thinking about these things in a cross-sectoral way, I think it becomes possible to use some of these new policies and legislation to that advantage. So it's about knowing what people need and want and creating a system for that.
Yes.
I often wonder if we have a place in our community now for a public health campaign, like an ad campaign or something. Did you know that you're an equal partner in your healthcare and you have a responsibility to make your own choices? I work as a registered midwife, and we've been legislated and funded for almost 25 years, and part of the key sort of pillars of midwifery care, one of them is informed choice. So it's not our place to make decisions for our clients. It's our job to educate them and inform them and let them know what the community standards are and what the recommendations are from all of the research and the organizations. But ultimately, it's their decisions to make their own informed choice, and then we have to support them. And we do that because we believe in it, but also that's part of our model. We have an ethical requirement to support our clients in their choices, even if we disagree with them.
Right.
And when people come into care with midwives, we have a whole conversation about this is how we work, this is what informed choice means, and it's our responsibility to do this with you, but it's your responsibility to do this with us as well, and you have to make your own decisions. Some practices even have people sign an agreement, an informed choice agreement at the beginning. And so when I look at patient engagement and all of these, patients as partners, I think, do we even know that? Like, as the general patient who goes to see their doctor for an issue, are they even aware that they are now being expected to engage and be their own expert in their health?
Yeah.
It's really, I think those are really interesting and important statements. And we can look at other countries who are further along in the evolution of what we're trying to do here through this work in Collingwood. I had the good fortune of spending a study week in Denmark, looking at their health system and the education of their health professions. So they're a few years ahead of what we're trying to do. And first and foremost is their campaign about the citizens, they call them, and their responsibilities for their health. And so it is an evolution, and as Sarah said, we're recovering a little bit from the previous system that we had. So I think your points are really important, and I think we can learn a lot from each other, but we can also learn a lot from looking at jurisdictions that are further ahead. And when someone asks the question of Dr. Tepper, who's doing this really well, sometimes we can look to other countries as well as other jurisdictions within Ontario. So there's definitely that component to it. So excellent point.
And the other thing I'd like to mention, excuse me, is that we have all these smaller pockets in terms of trying to raise awareness. So there's the Choose Wisely campaign that's out right now. So and they actually have a bit of information to say to patients, or these are the questions you should be asking of your physician. So it is part of these little pieces to say that you do have a role. There is opportunities for questions. So how do we start again to slowly chip away at the notion that I am not a participant, I'm there to receive your expertise, which you are, but how do we do it in a more fulsome way? I saw another, yes.
Well, and I think all the regulated health professions actually have a mechanism for this, which is called informed consent. So the midwife was talking about informed choice, and that's one of the words that they use in their culture, but if we all really apply informed consent to our patients, we're actually encouraging their questions. Consent to it. This is what we recommend you doing. What are your questions about it? So the vehicle's already there.
Right.
It's just changing the language around.
Yes. Yep.
I think we have time for one more question.
We'll go to the back. Yes, yourself.
So you'll be focused a lot around nurses and physicians and everything, but I think it's also highly important to understand that the social workers and the child youth workers they all have a role in playing and practicing this because they are working hand on hand with supporting the youth, and so I think it's really important for them to be aware of this practice.
Yes.
And I know that there's certain parts of Ontario that do practice this. Like I know myself, I've done it once more, and I've had a patient say, "Oh, well, you're the expert, so just tell me what I need to do to get better." And it's kind of like taking it back and understanding where you're at and saying, "Well, I understand that I'm the expert, but you're the expert as well," and really bringing it back to them.
Yep.
So I think that's another big emphasis of not just focusing on nurses and doctors, but really focusing on people who are supporting those groups.
Yeah.
So excellent point as well. So we're almost out of our time, but in closing, I think our challenge that we wanted to present and to have us all think about is what type of health system are we trying to create? And with these ideas in mind, what can we do when we have these effective collaborations? When we think about, who all needs to be involved in structuring the system, and how do we structure these changes, because there are many changes afoot, and there are many documents and many policies and pieces of legislation that can really support us, and how can we use those to our advantage so that Collingwood and other towns within our LHIN can be as healthy as they possibly can, and that we can have a health system that really promotes quality and effective patient outcomes. So thank you for your attention.
Thank you.
Great. Great, thank you. That was excellent discussion, and it's great to have the voices in the room being able to dialogue and talk amongst ourselves about these issues. That's fantastic. Our next topic is Dr. Kate Colson. She's our final speaker before our first poster viewing break. Kate is finishing her second and final year in McMaster Rural Family Medicine program. She does hope to join the local family health team upon completion of her program and continue to work and live in our community here. So, Dr. Kate Colson.
Thank you. Can you hear me okay back there? Great. Okay, so I'm certainly honored and very humbled for the opportunity to speak today at the Research Day. We've definitely been focused today on quite a think global perspective. I'm going to drive it right down to acting locally, and we're going to be talking about our local research project that we did as second-year residents, an evaluation of our own residency program and implementing a program that we hoped would change our own skill development throughout. So my partners in this project were Drs. Adam Bignan-Colo and Thor Ellingson, and it was an implementation and evaluation of a self-directed longitudinal procedural skills curriculum.
So today I'll be outlining the design of our curriculum. We'll be discussing the motivation behind our project, exploring some of the evidence behind our curriculum design, and reviewing why we selected ultrasound as our pilot skill and the results of our survey data that we completed. We'll talk a little bit about legacy and limitations of the project and leaving time at the end if there are any questions. As I say, I think that this is sort of an idea of driving down into your own lives in your own clinical area, how you can change and improve quality. So, as I say, we identified an area for quality improvement within our residency training program. It was a longitudinal self-directed learning model that could be implemented for various procedural skills required of the rural physician. Our initial topic was ultrasound. This is our 16-week ultrasound curriculum. So we had 4 different modules that we did, and we repeated each of the modules 4 times. Each session, we performed the same scans on 3 different emergency department volunteers. Each resident was responsible for reading an emergency department echo textbook before we started the curriculum. Then we reread each chapter prior to each session. So essentially reviewed the content 4 times throughout. And then we shared resources like 5-minute sono videos to provide another viewpoint and to deepen our understanding. A letter with the project explanation and sample patient consent was provided to the Chief of Emergency Department. Approval for the ultrasound project was granted. In terms of our pillars that we built our project on, this quote nicely frames the first pillar of our curriculum design: the importance of practice garnered with repetitions over time. Specifically, the idea of interleaving practice between 2 or more subjects. Retrieval becomes harder, feels less productive, but the effort produced results in longer lasting learning. The second pillar is retrieval-based learning. So the idea that the more often you have to retrieve information in different settings, the more durable that information is and that learning is. Specifically in this study, that repeated retrieval resulted in a 400% improvement in retention. That was certainly what we were hoping to end up with at the end of the project. The final pillar involves self-directed learning, the foundational adult learning concept that McMaster, Harvard, Calgary medical schools are built upon. This is a meta-analysis of 59 studies comparing mostly residents and nurses to other learners, and found that self-directed learning was associated with a moderate increase in the knowledge domain, and when learners were involved in choosing their own learning resources, self-directed learning was more effective. Advanced learners, like nurses and residents, seem to benefit more from self-directed learning. There was a highlight in the evidence towards significant in skills and attitudes domains, and you'll see that that was mainly what we were assessing here. Why did we choose ultrasound? Well, it's an emerging skill within the family physician's office. Current applications include abdominal aortic aneurysm scans, as well as for all obstetrical exams. This is already done at one of our local physician, Dr. Mitchell's office regularly. Also, and most importantly, within the emergency department, the applications are ever growing. But research has shown that in 10% of cases, bedside ultrasound suggested a new or clarified the diagnosis and avoided further imaging in 53% of cases. What were some of the barriers that we came across in our research to implementing ultrasound as part of a physician's practice? Well, the big one was ability to maintain the skill. So 44% of rural ED physicians surveyed did not perform ultrasound because of the difficulty in maintaining the skill. That's why the curriculum development and structure of it was so important to retain the information. And then lack of quality assurance. So 2 studies spanning over 25 years of American legal cases didn't report a single case against an emergency physician who failed to interpret or made a mixed diagnosis based on point-of-care ultrasound or POCUS. But they did report 6 successful cases against physicians who failed to perform POCUS when it was within their scope of practice, and it delayed a diagnosis or resulted in a patient demise. Other key barriers included lack of training and lack of equipment. So how did we collect our data? Each of the 3 residents involved completed a weekly 12-item qualitative survey. Results were marked based on a Likert scale from poor to very good, and we also created an initial program survey to assess background experience and training in ultrasound, which both through medical school and our residency thus far was almost nothing. So I apologize for the eye chart here, but I'll explain. It represents comfort level on the y-axis from 1 to 4 and number of weeks of sessions that the program was delivered on the x-axis. The colored lines represent the 5 questions answered each week, self-reported confidence and competence using the ultrasound skills. So in general, you can see that the residents started with very little comfort on all areas measured and finished with essentially good comfort. And there was a rapid rise in pre-test comfort level followed by a slowing of improvement as you moved along. And this is probably pretty characteristic of how residents would rate themselves generally. So this, there we go. Generally, this graph speaks to residents' overall feeling that the curriculum was worth the time invested. Specifically, the y-axis represents 4 being strong agreement with the statement, and the x-axis represents the other 6 questions measured on the survey. The tricolored bars represent slices in time. So blue is the beginning of the survey, week 1, orange is the middle, week 7, and nearing the end, gray is week 13. Based on question 4 in the middle there, residents did not feel like the curriculum was too much work for the benefit. Question 5 stated, I would benefit from supervision, was clearly a resounding yes, scoring an average of 3.3 out of 4 at all time points. Again, maybe speaking a bit to insecurities that we see in residents. But certainly question 6, this has increased my use of skill in clinical practice, clearly increased throughout the study time period. So as we move into our discussion section, our successes, we found that this was certainly a feasible curriculum. The residents' attendance was optimized. They felt that it was worthwhile, and it addressed a clear gap in our residency training program. It effectively increased confidence and competence in practicing the ultrasound skill, and it optimized best practices in adult learning. It was free, which is ideal in a very resource-constrained setting. And it certainly created a legacy program. The R2s of the incoming class of 2016 also created the curriculum and completed the surveys. However, it was outside of our scope of this project to include their data within our reporting. And it's certainly easily generalizable to other skills. Our main limitations that we found is that this was not a validated survey tool. There was no quantitative analysis of the skills, so no one came in and measured how we were in terms of achieving image generation at the beginning versus the end. It was self-directed, which meant we had no formal supervision. And we all recognize that it didn't replace formal ultrasound training. In fact, we would recommend that residents would go on, complete this curriculum, and then would benefit more from the snapshot training that is often available in a weekend course. And the largest limitation certainly is the small number of participants, so only the 3 residents within the Collingwood Rural Residency Program. So again, we thank you very much for your time and allowing us to present our project today. Are there any questions on the implementation of the program? I think we're just about out of time. So, oh, yes, at the back. So I'm really glad you asked that question because it drove home what we were trying to achieve with the project. And that was, in our initial phase, we wanted it to be as feasible as possible. And with an already very condensed, very disparate rural residency program, adding any content, particularly content where we have to be together, is extremely difficult. So one of the slides that didn't come up was just talking about things like convenience. So we had to do it at 7 a.m. on Wednesday mornings before our rural family practice day back. That was just after shift change in the emerge, so it would be early and we'd be able to get access to the ultrasound machine. So trying to add another layer of asking a preceptor to come in, although I think all of us would have preferred that, we thought for our first pilot project we would try to do it completely self-directed and self-evaluated. But for future generations, we strongly recommend that to the next generation of residents. So yes, so the great thing that we saw was that our R1 class that came in this year they all repeated the project. They all completed the surveys each week. And our hope is to get each of them certified in ultrasound so that they will actually be able to proctor the year ones coming in. So the idea of this is to generate a clear legacy program within the rural family medicine program for procedural skills training, where it will essentially be residents train the trainees and then they become the teachers. That was the dream, but it's just implementing one piece at a time. That's exactly, and so that's what happened. We had a resident who did attend, and his intent was to be able to certify the first-year residents. But again, our challenge becomes timing, time. So it's just a matter of, do we try to engage some of the local physicians who are already also time-strapped to become involved in the program and assist with some of the monitoring of scans. Thank you very much. Wow, I really attached that on there.
Thanks, Kate. Great. Thank you so much, Kate. That was wonderful. So we are just about to start our first poster break. Posters are hung outside the walls. We're on time. Oh my God, this is fantastic. So we'll ask that you come back at 10:15 a.m. There is coffee, there's refreshments at the sides of this room here as well. But just for housekeeping purposes, again, this is the survey that you had here. There was a front, there's a back. Please do the front side before our mental health stream that's coming up next, and then the back side will be done afterwards. In addition, there will be another evaluation on your seats. Okay, see you at 10:15. Thank you.